G'day, my name is Pete and I would like to talk to you about the HIDS study. So that's the haemofiltration in the ICU and diabetic status trial. Special thanks to Dr. Tobin, Prof. Chan, Associate Professor Lividios, for helping me so much with this project, particularly Prof. Chan with the stats. It's been reviewed by the Journal of Anesthesia and Intensive Care and using a slightly different model. So what are we talking about in a nutshell? So it's a retrospective cohort study of 7,500 patients at a major ICU using regression analysis to control for variables and finding no differences in infection rates, death, oliguria, inotropic usage, etc. if you're diabetic or not, but significant differences in hemofiltration and length of stay. Background, we all know diabetes is a big problem in Australia. Not much research has been done, particularly on diabetic status and hemofiltration. There's no actual guidelines for diabetic care specifically in the ICU. It's a big problem that's getting worse. It's doubled in size in terms of prevalence of diabetics since 81, and it will double again by 2025 according to AusDiab, and it's in the media. It's also very costly. Inpatient care represents the biggest cost slice of that pie rather, and obviously ICU is a very expensive place to stay. AKI is kind of what we're talking about here, and renal replacement therapy, i.e. hemofiltration, which commonly complicates the course of acute illness. We know that diabetics are more likely to suffer AKI, and it would stand as a logical extension then that they might also be more likely to need hemofiltration. But no one's actually specifically looked at this question, even though it may actually seem logical. Similar stuff has been done, but not quite the same. Like chronic renal disease, more likely to have RRT, but no one's actually looked specifically at diabetes. Alright, so that's really our aim. Is diabetic status an independent risk factor for needing hemofiltration? We also looked at a few extra bits and pieces like mortality, documented infection, if you were more likely to get inotropes being diabetic, for example. How do we do that? Well, we got all the admissions from a 7-year period, and there was no change of practice, and we're talking about the St. Vincent's ICU here, big ICU, admits about just over 1,000 patients a year. So of all those patients, nearly 8,000, we cut out a few. No exclusion criteria, it's just simply duplicates were removed. And there was about 5,500 non-diabetics, about almost 2,000 diabetics. They had very similar baseline demographics, except for stuff that you might expect, like a history of hypertension, a history of renal disease. Otherwise, it was pretty similar. Statistical analysis was all pretty standard. Confidence intervals, p-values, and we'll get into some of this more specific stuff. The variables we chose in the end. So obviously hemofiltration, binary, did you have it or not? History of diabetes, binary, did you have it or not? Age, your sex, hypertension in your history, were you a smoker? Did you have acute renal failure on admission to ICU? Obviously that would make a big difference in that you actually might have been admitted specifically for renal replacement therapy if you had AKI. Did you have a history of chronic renal disease? Do you have a history of cardiac failure? And was your diagnosis for admission to ICU renally risky or not? For example, you might have been admitted, there were 81 different possibilities for admission, one of which might be meningitis, which was thought to be not renally risky, so that would be a 0 for that variable. Other diagnoses were considered renally risky, for example, sepsis, urosepsis, cardiac failure, stuff that consultants might theoretically put you at a higher risk of renal replacement, renal failure rather. And your ICU admission source, did you come from emergency, theatre, hospital transfer, or the ward? You might imagine someone might be a bit sicker if they've just been transferred from a hospital, for example, maybe. So the model had a lot of scope for covariates, given there were so many events, 10 events per variable. But we chose them based on two things. Statistical significance using forward and backward analysis, and clinical significance after we identified significant variables in the first step there, as discussed with some consultants. So the model, how did it perform? So we tested it in terms of calibration, which is the same way as saying goodness of fit really. It should be parsimonious, so you can test that in the quality and a binary way. So our binary way for our model here, the Homser and I can never say this word, Lemshauer test, was significant, and the Nagle-Krokey R-squared, so we're using an R-squared obviously because it's binary, not as a pseudo R squared rather, not a true R squared because it's not a linear model, and that accounted for about 40% of the variance. And discrimination is the other major way of testing your model, and we use the area under the receiver operating curve, having its history in radar, and some rules of thumb there. If it's above 8, it's considered pretty damn good. So the full model, it was 0.87, which is pretty damn good with good confidence intervals, versus the diabetic status of 0.55, just diabetic status. So the full model, if they had all these things and you just randomly plucked someone from that positive group with those things, they'd be 87% more likely than not to have haemofiltration, or whatever you're measuring. So those results, this is what it's all about. Odds ratio of 1.47 if you have a history of diabetes. You have an odds ratio of 1.47 of getting haemofiltration if you have diabetes versus not having diabetes. That's statistically significant with good confidence intervals. And that's essentially what the whole study is there to show. And obviously, having a diagnosis of being renally risky was even more significant. Having chronic renal failure or acute renal failure is even more significant. Hypertension was not statistically significant. We also did a risk ratio with similar outcomes, obviously a bit more conservative. We're using a similar model, but I'm not talking about that today because we decided on using odds ratio because it was a prevalence-based retrospective study as opposed to an incidence-based prospective study. So just a quick little bit about challenges I had. I had such a large sample size that it's actually presented with its own difficulties. Obviously, if you have such a large sample size, if you're just doing subgroup analysis, taking, let's just say you do 20 subgroup analysis, then obviously you're going to get significant results there, even when they're not truly. And a good example of this was in the ISIS study in the Lancet, where they did subgroup analysis based on zodiac sign at a protest because they didn't want to do the subgroup analysis, rightfully so, and they did find significance. And I just did the same thing out of interest on mine. So I gave everyone their true zodiac signs based on their date of birth, and you can, for example, you're actually statistically more significantly, you're more likely to require haemofiltration if you're a Capricorn, for example. And obviously this is just bogus, but it's something that I needed to be aware of having such a big sample size. Multicollinearity was a big problem for me. I originally had a big model here with Apache score was one of them, and there were some problems. The three major problems you get with multicollinearity being high standard error, beta weights being affected, and statistical significance being affected, and model convergence not really working, and that was a problem for me. I had Apache and AKI in there, and obviously Apache also includes AKI, so it took me a while to realize that. I took it out, and then I did a final multicollinearity study on mine, looking at correlation analysis. It was all good. All the variables were under 0.08, well under 0.08, and then the variance inflation factor, which is kind of like the inverse of correlation analysis, was all good. They're all well under 10. So all these numbers just tell you that multicollinearity probably is not a problem with this model. Yeah, that's it. Now, conclusion. So the findings of the study show that diabetic status is an independent risk factor for haemofiltration at a major Melbourne ICU, even when controlling for those covariable. And what are the implications? So renoprotective measures around three things: circulating volume, minimizing contrast, avoiding nephrotoxics. So we know that there are targets for circulating volume for other conditions like sepsis. Maybe a higher circulating volume for diabetic patients might be protective, or maybe we just have to be more sure that they're targeting that volume. For example, you might want to put a central line in diabetics more readily, or have a lower threshold than not, maybe. Contrast, well, prior studies have shown that there's actually no difference in contrast-induced nephropathy in diabetics, so maybe this isn't a path that we should go down. Nephrotoxics, so I just found this as an interesting little side note to this study. Dobutamine is a kind of debunked theory that it might be renally protective as an inotrope, and in this population of people, they actually had higher rates of dobutamine usage in the diabetic population. So people are obviously using it this way. It's not been studied, as far as I'm aware, particularly in the diabetic population, so that could be an area of further research. Limitations, it's a single center study, so and renal replacement therapy the initiation of that, it lacks consensus and consistency, and there's no predefined criteria in my trial. There's no differentiation on the type of diabetic you are, and the approach to renal disease is a bit clumsy in that it's either just binary, you have it or you don't. It wasn't a scaled variable like on eGFR, which has been shown to be associated with length of stay. Why is this study good? Well, it's a common condition, it's getting worse, it's a unique study, the question has not been answered before, and it's a large sample size and statistically robust. Thank you for listening.